our speakers will come up for questions. I have to answer this question, the most fantastic question, and that's, can we get a list of normal adolescent behaviors? And the answer is no. Actually, adolescence, and you look at adolescent brain development, it's very similar to brain pathology. John Oldham, who's the president of the American Psychiatric Association, asked me, well, what about this adolescent BPD? And I hypothesized this, this set of identical twins, one of whom, identical twins who are doing exactly the same thing. All having sex, doing lots of drugs, experimenting with different, driving fast and everything. And one with BPD and one without BPD. How can you tell the difference? And I think that the important thing is that when doing these assessments, we have to know what the function of the behavior is. So if somebody is just, you know, having sex because that's what they're doing, well, okay. But if somebody's doing it because they want to regulate themselves, they want to feel more connected, then that can be problematic behavior. If someone's just experimenting with drugs, okay. If somebody's using those drugs in order to regulate their emotions, that can be problematic behavior. So we really want to know what the function of the behaviors are. But to a specific question about normal adolescent behaviors, you know, there is typical adolescent development, and the APA and American Pediatric Association has some outline on that. But I'm going to try to get to the questions for our experts, and there have been a lot of, I'll try to categorize some of them, and any of our experts could take these questions. The question of substance abuse has come up. So first of all, is there treatment for comorbid substance abuse? What does substance abuse do to the treatment of borderline personality disorder? And if people could talk a little bit about that.
I won't directly answer that question, but what's interesting and sad is that the disorder that most disrupts remission from BPD is substance abuse. It's not major depression, it's not bipolarity, it's not PTSD. And I think the really sad thing is that substance abuse is often underdiagnosed in young women with BPD. Parents and treaters will say, well, she's just self-medicating. Well, if her self-medication is 3 to 4 nights a week, she's smoking on the floor, lying around vomitous, and has blackouts, she's actually got a substance abuse problem. Whatever the right treatment is for that, I'm not an expert in that, but that disorder has to be paid attention to first. You can't just ignore it and go past it.
We see a lot of adolescents who have comorbid substance use with BPD, and I guess if it's not a primary disorder, in other words, if they have an active heroin or amphetamine addiction, they need to go to rehab for a certain period of time, detox, cocaine, etc. But if they have often alcohol or cannabis abuse in addition to BPD, we will target that problem behavior as we target self-injury, as we target disorder eating behaviors, and we have them self-monitor, and we have them do chain analysis of that behavior, just like everything else. And we may have adjunctive 12-step and other programs that go with us, but we are happy to treat that in a DBT outpatient model, depending on the severity of it.
Jill, you talked about middle path. So what would happen if an adolescent said, well, you know what, when I smoke marijuana, I am at much less risk of killing myself. So what the parents see is, wait a second, you're using all this weed and all this sort of stuff, but on the other hand, it is less of a problem in terms of self-injury and suicidality when I'm on weed.
Well, I think that the DBT approach to that would be to validate that feels valid for the adolescents, and it might, in a harm reduction model, it might, for the moment at least, be safer than committing suicide, attempting suicide, or even self-injuring. But so it would be validating that, but also providing psychoeducation about long-term use of marijuana and its ill effects, and that would absolutely still be a high priority target to use. So it makes sense, you feel better, you're alive at least for now, and at the same time, we're still going to help you work to reduce that.
we got a lot of questions about the cost of DBT. A lot of the DBT programs are self-pay programs. There's very little insurance reimbursement, so that's the cost question. If anybody could talk to that. And then there were a lot of questions about how do we get DBT into schools, but all the way not only to schools, from kindergarten right through college, and are there colleges and schools that are supporting DBT? So if people could tackle the cost question.
So the cost question, that's a complicated question. It's a systemic issue, right, from the larger healthcare system. It's a problem with lack of training and resources devoted to training. So there's a lot of moving parts to that. You know, for example, at Montefiore Medical Center where I work, we have a Medicaid paid clinic that we treat individuals with Medicaid and some commercial insurance. So there are places out there, they're few and far between. So I think that's partly, as I said, I think there needs to be more training and dissemination of this treatment in other settings where they're hospital-based settings, and I think hopefully the healthcare system will be able to embrace this and pay for this more readily than they do now, and that's why often they do have to go to self-pay. It's a broken system, and it's very painful. In terms of an education perspective, getting into schools, it is my life mission, I guess I would call it now, to collaborate with people to figure out a way to create this curriculum and get this into early elementary school, and so that people have these skills and that they can carry with them, and then maybe be reinforced along the way. So I'm talking about a primary prevention intervention where they learn skills in regular education. Yes, it's already, as we've heard, in schools in Ardsley and Pleasantville and other places, in school districts for kids who have multiple problems, and that's incredible, and that's wonderful, and I think it's saving a lot of tax dollars just right there from a systemic perspective. But I think there's a lot more that can be done, and I look to people out in the audience and others to see where we can combine resources and develop some protocols for younger ages. And I think our friends, the Mazes out in the University of Washington, we're going to hopefully get some curricula together that can be actually tried out in some local schools and see if we can get this into education.
Dr. Miller, you talk about the biological predisposition, but has this biological predisposition ever been actually shown, or is it just a hypothesis? And has anybody with a biological predisposition gone on to not develop borderline personality disorder?
Well, I think as Mary said this morning, I think there are some studies actually in terms of amygdala brain imaging, fMRI studies, brain imaging studies, and the anterior cingulate in terms of amygdala. There's clearly some brain differences even in adolescents. It's been definitely shown in adults that are the emotion centers of the brain. So there have been some preliminary research on that, which suggests that it's kind of supporting Marshall Linehan's bio part of her theory. What was the second part of your question, Blaise?
Have there been people with those predispositions?
Yeah. So I have no doubt, and again, this is an empirical question, I have no doubt people with those predispositions wouldn't always necessarily develop BPD, and it is, if you think about the theory, it is the environment in such a way that it is impacting that individual with the biological vulnerability to then develop the diathesis and the stress to yield over time BPD.
Another question is, we've talked a lot about DBT here today, but what about some of the other treatments in adolescence, transference focused therapy, STEPS, schema therapy? Anybody here know much about those in adolescence?
I don't know of those other approaches to being applied to adolescents. I've heard anecdotally that mentalization has been used with some adolescent patients, and you would know much better because you've been doing it at McLean. But I don't know of research studies on these other treatments with adolescents yet. I think they'll
Later we'll have Dr. Hollander talking. He's our mentalizing expert in adolescents, although I don't know that there have been specific studies of MBT in adolescents. But there was Somebody had a point?
Jeremy.
Okay.
Actually, there is a New York hospital there doing a study of EFT using alcohol for
With adolescents?
Yeah.
So this is Dr. Jeremy Stone, who's reporting that there's a study on transference-focused psychotherapy being conducted at New York Presbyterian, just right literally across the street. So if anybody's interested, talk to Dr. Stone.
But I'll find it in my program.
Oh, yes. Could any of our experts comment on the distribution of intellectual and cognitive abilities in borderline personality disorder?
We've assessed all our subjects by IQs, and interestingly enough, the women have a normal bell-shaped curve, the people on the low end, most of the people in the middle, and some people at the high end. The men are very different. There's almost no one in the middle. There are a lot of people at the low end, a lot of people at the high end, and I think that's really interesting. I think it needs to be taken into account when creating or adapting treatments for adolescents with BPD.
There were a lot of questions about people who had children with and young adult children with very clear symptoms of borderline personality disorder, but that the clinicians were not making the diagnosis. And could our experts talk about why this is and issues of stigma?
If you Google borderline personality disorder, you come up with some of the research articles rather than theories that were developed many years ago by some of our forefathers. It's very disconcerting, and some of the constructs describe projective identification, manipulation, aggressive drives to get out of control. Raise your hand if you want that client coming to you next. You know, those ideas are so aversive and frightening to most practitioners. So that yes, if you read that and you say, that's my child, oh my goodness. Now, if you look at Mary's research that is suggesting that after this many years, people will age out, if you will, and not have the disorder anymore, that's a whole different type of literature that is instilling hope and restoring hope as appropriately, I think, for people with this condition and the families. But I think practitioners are not familiar with all Mary's research. And many practitioners don't know about evidence-based treatment, sadly, to date. There's so many people out there doing treatment as usual and have no idea what can be done in an effective way to help people with this complicated disorder. So again, I go back to graduate schools and I say, please get evidence-based treatments into your graduate training so people can learn this, and go into the community, get workshops and trainings for people to learn these therapies. It can be done, but there's a certain problem in our system, again, about not requiring people to do more evidence-based treatments, in my opinion, and I think more education needs to be done for families so they can learn that this is not a hopeless condition, and we can inspire hope further.
Some questions on PTSD. Dr. Kaplan, how do you treat PTSD trauma victims who do not have a clear or sufficient memory of a trauma? So, for instance, children who were adopted before age 3, who may have been in orphanages and traumatized there. And is there empirical evidence for EMDR?
In terms of that, it's always a dilemma. How do you deal with what they call flashbulb memories or even pre-verbal memories? The current evidence base is that if there are some clear memories, even if they're not complete memories, but someone's fairly sure that something happened to them and they remember either some visual or auditory or narrative details of what happened, that those memories can be worked on and cause amelioration in the PTSD symptoms. Again, you have to be very careful not to encourage the client to embellish those symptoms. The idea is never to ask them, just by repetition, things become clear that were not as clear in the first repetition, but that's really different than the process of fishing around to try to complete a memory, either on behalf of the client or the therapist. So the issues of incomplete memories and being over and under engaged in the actual exposure are all, they're workable. The idea of having no memories, but someone else knowing that something happened to you, which is this whole pre-verbal issue. You see this a lot in cross-cultural adoptees and early to mid-range adoptees, where parents do have the information and even physical proof that something happened, but the person has no memory of it. You know, there are ways to deal with people's trauma narrative then that has to do with their adoption, has to do with how you live your life when you know you can't remember salient things, and that becomes part of the environment that people are trying to recapture and expose themselves to and not become avoidant around. But the idea that you can really expose someone to something they can't remember just has never been shown, evidence-based. And EMDR does not have any scientific validation in children and adolescents. It does in adults.
You know, you talked about the involvement of parents, but what about very traumatized children and adolescents who are in residential settings where there are no parents, or they're in foster care or something like that? How, you know, is this more difficult? How is the work done in terms of the absence of family?
I think it's always more difficult in the absence of family, and in fact, Mira and I spoke last week before coming here speculating about why you may have found a lower rate in your adolescent population than in your adult sample for trauma in childhood, and whether that was correlated perhaps to the socioeconomic standing of the population that you were looking at for adolescents. I think we deal with a lot of adolescents where family members are not available, or they're in foster residential care. Nonetheless, I think what it comes down to is that if somebody is experiencing trauma memories, if they are dissociating, if they are feeling avoidant and numb, and they are just beleaguered essentially by the PTSD symptoms, you get a variation. Some people report, I have the symptoms, they're mild, I can live without tackling them directly. They are not leading to secondary unsafe behaviors. But when they are moderate to severe, I think then they get dealt with the same way with the clinician, and there's not really good evidence about, you know, family support is better, but how much better? I don't know any studies that really show that.
Okay, so here's what we're going to do. There's just so many questions, obviously generated a lot of questions. So actually, if you could put the person that you would like to answer the question on your card, and then what we're going to do is I'm going to distribute these cards to the various clinicians, and if we don't get to every question, which we probably won't, we will have them answered on the website. But the issue is now that there's 320 of us, and this is going to be like a mass scramble, like a Miami football game, you know, in the fourth quarter, 30 seconds. And what you have to do is you have to rush out, go grab your lunch, and get back in your seat, because at 12:15 we're going to have Brandon capturing our attention for the next half hour. So I'm going to just let you all leave a few minutes early, go out, grab your meals, and come back and sit down. Thanks.